Welcome to this session entitled Shocking Sleep Dilemma. And we decided to choose topics and presented it as a debate, pros and cons, but really not much counterpoint. Each presentation will be 10 minutes. Moderators are Dr. Praveen Raj and Dr. Paul Burton, and any of the speakers are invited to come at the podium at this time. Is Dr. Sakurai here? I'm not sure if he came in from America. If not, I will make the presentation for him. The first topic is on survival is higher with sleeve gastrectomy than with gastric bypass patients. So may I have the presentation. It's a presentation that I prepared for the International Surgical Week. Hello. So these are my disclosures. And if we're talking about surgery for diabetes, I must say that I love this randomized control trial done in Italy from Gronnier and Rubino that looked at medical therapy, gastric bypass, and BPD. And in this trial, the BPD had the lowest hemoglobin A1C. Now, at 5 years, they published their results, and the complete remission was 63% for BPD and 37% for bypass. But at 10 years, it got worse. It got 25% for bypass and 50% for BPD. So if we have to choose a surgery for diabetes, we're probably going to have to choose something that is similar to BPD. But BPD is not done anymore, and the closest thing is the duodenal switch. And if we look at beyond 12 years, you can see that the remission rate is between 88 to 90% at 150 months with duodenal switch. When we look at the sleeve pass randomized control trial that looked at sleeve versus Renoir gastric bypass, published in JAMA in 2022, there was not much difference in the weight loss between the two studies. And if we look at glycemic control, whether it's year 1, 3, 5, 7, and 10, there was no statistical difference between the two groups 10 years later. If, like Dr. Schauer just presented, you put all the randomized control trial together, this was published in JAMA 2024, there was no statistical difference between sleeve and bypass. They were unable to show any differences at 12 years between the sleeve and the bypass. There was a difference between best medical treatment, but none for that. In the different groups, there were vitamins and anemia differences in that gastric bypass had statistically more anemia. There were more other vitamins and problems. Now let's get into what the topic is about, long-term mortality. There was a study by Korkulas from the University of Pittsburgh that looked at the 5-year cohort study of reintervention after sleeve or bypass. And at 5 years, there was more reintervention with bypass than with sleeve. Now, this is looking at 11,000 bypass and 1,600 sleeve. The 5-year death rate was 1.3% for sleeve and 1.9% for bypass. There was a hint that you had a 50% higher mortality over time with bypass. So then there was another study that looked at sleeve versus bypass up to 5 years. This is 57,000 sleeve and 38,000 bypass. You need to reach these numbers to look at mortality. Mortality was higher in bypass, complication higher with bypass, hospital stay higher with bypass, emergency department visits higher with bypass, higher reintervention, higher reoperations. The only difference was revision. Revision was higher with sleeve, and enteral access was higher with bypass. Now, the same data was looked at for Medicaid patients in the United States. These patients are in the public, kind of more public. About 25% of patients in the US are Medicaid. And this is looking at 132,000 patients, close to 85,000 sleeve and 48,000 bypass. The mortality after 5 years was 1.3% for sleeve and 2.2% for bypass. Now, these are small, but if we look at 1 million morbid obese patients, that's thousands of patients that are dead in comparison to sleeve gastrectomy, for example. And looking at mortality was higher with bypass over time, complications, hospital stay, emergency department utilization. The revision was higher with sleeve gastrectomy, and reoperation was higher with bypass. And what's happening is that they have emergent operations that are often like bowel obstruction, ulcer disease that perforate or bleed, biliary problems. These are emergency surgery that are performed with gastric bypass versus revision, elective revision of sleeve gastrectomy for weight regain, and they don't have the same mortality rate over time. Now, if we look at binational cohort study, this is other country, Finland and Sweden, put together, and you look at the sleeve gastrectomy close to 10,000 patients versus 51,000 bypass. Bypass is more performed in Scandinavian countries. And you look at mortality, all cause, 1.3% for sleeve and 2.8% for bypass. So this is also reproduced in other countries, in other cultures, similar to what we see in the United States, that the mortality is double over time. Now, what are they dying of? If we look at this study that looked at the record in the Utah of 4 million people that served as normal cohort versus a bypass bariatric study of 27,000 patients, and you look at the outcomes, mortality after bariatric surgery, it was higher in external causes of deaths, all accidents and adverse effects, and suicide. Also chronic liver disease and hypertensive heart disease was higher than the general population. There was a breakdown in operations, different types of operation, bypass, bending, sleeve, duodenal switch. And what you can see in all of those is that sleeve had lower mortality than Roux-en-Y gastric bypass in all these different causes, including type 2 diabetes, because many will tell you, you've got to do a Roux-en-Y gastric bypass for diabetes. Yet, if you have slightly more effect on type 2 diabetes, but you're dead at the end, what does that serve a benefit for the patient? But even in diabetes mellitus, the sleeve had lower mortality than Roux-en-Y gastric bypass. So I have to conclude and summarize that there is small weight loss differences, and are they really significant? Diabetes resolution, at least in the combined randomized control trial at 10 and 12 years, there was no statistical differences. The long-term mortality is lower with sleeve gastrectomy than with gastric bypass. This is despite higher revision rates with sleeve gastrectomy. And of course, sleeve gastrectomy has more options for revision, but that's going to be another debate. Thank you very much.
Thank you very much. Thank you very much. You're convincing, Michel. You're convincing, and I try to be on the other side to modulate your message from the last speech. And there are my slides. And I have no conflicts of interest to report. I'm the PI of a randomized study, the best, which I will talk about a bit. So what are the problem? I see you're making a good case out of arguing from data that are basically observational. And what is I know that David Otterburn and others have been tried their best to do the propensity score matching between the groups. However, they always suffer from bias. And since we're looking at that small differences that you're having in those studies, I think we should be very cautious in claiming that there is a difference, because we don't know if the patients were really the same in both groups, that there is not a systematical bias in selection for different procedures. Is there the same setting for performing the different surgeries? Are there the same expertise for doing the two procedures? So they are kind of random questions that you could put up. And basically, we don't really know if we can trust data. We just observe an association for which bias can be the explanation. And that is something we need to take into account when we look at observational data. So how do we address a question like serious adverse events or mortality over a long time? How is this most adequately addressed? And it would be in a large-sized, multi-center randomized clinical trial involving more, same thing, a full system of performing bariatric surgery. Unfortunately, we have this in Sweden now. We have data coming up. We don't have the 5-year data, but I will present to you some of the perioperative data on the randomized trial between sleeve gastrectomy and gastric bypass, 1,754 patients. And why is, I just need to give you a little bit of context of where we are coming from in the data that we are presenting from the Swedish and Nordic side. We have had the quality registry for bariatric surgery since 2007. We know that these data that are entered, they are validated, they are controlled independently, and they cover 98% of bariatric surgery in Sweden. And we know that we have 100% follow-up for mortality. So Norway was also a part of this, a minor part of this study, but they have 88% covering of their bariatric surgery. So the bypass equipoise sleeve trial BEST is, as I said, a randomized clinical trial. We used the registry as a case report form, and we have co-primary endpoints at 5 years, which is weight loss, which would be the best surrogate variable, but we also carry substantial adverse events in terms of superiority. And our hypothesis is that sleeve would have, if sleeve have the same level of weight loss but less serious adverse events, then it would be superior. So that is kind of where we go into the trial. And it's recruited between October 15 and March 22. So here are the figures of the two groups in BEST. And as you can see, close to 800 patients in both groups, and they are similar for everything. But the question is, can we generalize those data, because there's simply just 1,700 patients and you have hundreds of thousands? So what we could do within the registry, that we could compare the results of the patients entered into BEST with the non-BEST patients in the same clinics operated during that time. And that is actually 80% of the patients, more than 80% of the patients that were not included in the randomized trial. So again, we are taking from April 2016 to 22, and now we have a different figure, that we have around 20,000 patients to be followed instead of just 1,700. And as you can see, the non-BEST patients on these clinics, they had more dyspepsia, so reflux was the exclusion criteria, and they had more type 2 diabetes, because they no, actually, there weren't no more of diabetes there. Anyway, so if we look at adverse events between the best and non-best patients, we start out with the best, and we see that the risk of having a serious complication that needed a reoperation was something like 2% in the sleeve group and 3% in the best group. And there were no mortality over 90 days in either groups. So of course, there are small numbers, but if we're looking at the risk of dying during the first 90 days after the procedure, we could see that it was very low in both groups. And as you can see also, the readmission pattern and the reoperation pattern was pretty similar between the groups. I received yesterday also some data from Johan Ottosson sitting in the audience, head of the registry in Sweden, and we can see that the 5-year overall mortality risk is around 1% for both procedures after 5 years. I refrain from giving those data in a slide because they are just preliminary and we haven't controlled them yet. So I think we should be cautious with this. But my conclusions are that if there is, and there might be, a difference between the procedures in the risk, at least with having the surgery in the 90 days after, there is a very small and limited differences between the groups. And it should not, in our opinion, be a main determinant for choosing either of the procedures. We have seen the same. You know that the bi-band sleeve trial is on its way out in the publication pipeline, and that will show the same thing, that there is no major differences between the procedures if you randomize the patient, if you do it prospectively and randomized. So how has this affected practice in Sweden? This is what we see now, that in 2014, when we planned and started the BEST trial, there was a steep decline in the numbers of bypass patients being done and a steep incline in the numbers of sleeves done. And we didn't know where to go. It crossed over and it was more sleeves than bypasses. But now when we entering this, the last phase of this trial, we see that it's rapidly going the other way. And this is the same pattern we see in Switzerland, we see it in Finland, and we see it in Sweden, where we're doing randomized studies, that we are going back to Roux-en-Y gastric bypass. It's 80% about this year, it seemed to be. So that concludes my talk. And from my side, I think the jury is still out, and I'm not claiming that there is no difference, but what I am saying is that it appears to be very limited, if there is a difference.
Dear colleagues, I'm Professor Caroline Gronnier, head of the Upper GI Surgery Unit in the Visceral Surgery Department at Bordeaux University Hospital in France. I am involved in both bariatric surgery and esophageal oncological surgery. I'd like to thank Professor Michel Gagner most sincerely for inviting me to take part in this fascinating session. And I am sorry I can't be here with you today. I will have a few minutes to convince you that the risk of esophageal and gastric cancer is lower after sleeve gastrectomy and gastric bypass. I have no conflict of interest on this subject. It is indeed established that there is a link between the development of cancer and obesity, such as endometrial cancer, colorectal cancer, and particularly for adenocarcinoma of the esophagus, with a relative risk of 4.8. The main risk factors for adenocarcinoma of the esophagus are Barrett esophagus and gastroesophageal reflux disease, male gender, obesity, and smoking. The impact of bariatric surgery on esophageal and gastric cancer remains controversial because on the one hand, it is expected that the risk of adenocarcinoma after bariatric surgery will decrease due to weight loss, and hormonal effects, such as insulin deregulation, which may be involved in carcinogenic processes in obese patients. But on the other hand, there is a fear of an explosion of the incidence of adenocarcinoma induced by gastroesophageal reflux after sleeve gastrectomy via the occurrence of an endobrachial esophagus. Then, what is the real impact of bariatric surgery on esophageal cancer? So we conducted with my friends Dr. Andrea Lazzati and Dr. Tigran Pogosyan an article published in JAMA on the risk of esophageal cancer after bariatric surgery on national health insurance data. To do this, we performed a cohort study between 2010 and 2017, including 3.6 million patients with obesity. From this data, we conducted a case control study comparing approximately 300,000 patients operated on for bariatric surgery with 300,000 obese patients who were not operated on. Over the period studied, we found 339 esogastric cancer with a significant decrease in the incidence of the cancers in the bariatric surgery group and a decrease in intra-hospital mortality in the bariatric surgery group. Multivariate analysis of almost 900,000 patients with a hazard ratio of 0.76 showed a reduction in esophageal and gastric cancer. The incidence of esogastric cancer was 6.9 per 100,000 persons per year in the non-surgical group versus 4.5 per 100,000 persons per year in the bariatric surgery group. Is there a difference between sleeve gastrectomy and gastric bypass? To answer this question, we used the following method. We included all patients operated on for bariatric surgery from the national database of hospitalization in France for adults over 18 years of age operated on for bariatric surgery, sleeve gastrectomy and gastric bypass between 2007 and 2020 with a follow-up until 31 December 2022. The primary endpoint was the incidence of esophageal and gastroesophageal junction cancers with the following international classification of disease codes. We then performed a Kaplan-Meier survival analysis, followed by a multivariate analysis using a Cox model adjusted for gender, age, and comorbidities. Thus, we performed a standard Cox regression with control for propensity score and a marginal Cox model after nearest neighbor matching. We included a total of approximately 370,000 patients, 80,000 of whom were followed for more than 10 years with a mean follow-up of 7.5 years. A majority of patients underwent sleeve gastrectomy. Their average age was around 40 years, and the majority of the patients had a BMI above 40. Concerning the incidence of esophageal and esogastric junction cancers, 92 cancers were diagnosed over the period. The majority of cancers were located in the esogastric junction and in the lower third of the esophagus, although 29% of the locations were not specified. No significant difference were observed between sleeve gastrectomy and gastric bypass in terms of cumulative hazard ratio of the incidence of esophageal and gastroesophageal cancer. The incidence of esophageal cancer was 3.9 per 100,000 persons per year in the sleeve group and 2.6 per 100,000 persons per year in the bypass group, with no significant difference, whereas it was significantly higher in the non-surgical group. However, several limitations need to be highlighted. The bariatric surgery population is younger, with a female-male sex ratio of 4:1 in the bariatric group versus 1:3 in the esophageal adenocarcinoma group. Moreover, there are no histological studies in this administrative database, and follow-up time is rather limited when considering the time required to develop esophageal adenocarcinoma, often over several decades. To conclude, bariatric surgery is associated with a decrease of esophageal cancer, with no significant difference between sleeve and bypass, but subgroup analysis in high-risk patients are needed. Thank you so much for your attention, and do not hesitate to contact me by email if you have any questions.
I would now like to invite Dr. Paul Burton to talk against esophageal and gastric cancer rates are lower after sleeve gastrectomy and gastric bypass.
Paul Burton from Melbourne. I'm an esophageal surgeon. So thank you for the invitation to your conference. Sort of from a small organisation, ANSGOSA, which is our National Esophageal Surgery Association, a little bit equivalent to ANSMOS, who we're very closely aligned with and try to collaborate a lot with, which I think is a unique part of the Australian landscape. It's very difficult to come into a conference of bariatric surgeons and be asked to tell you that your operation is causing esophageal and gastric cancer. Some disclosures. I'll just talk a little bit about the relationship between ANSGOSA, which is me, and ANSMOS, which is Dr. Ali and his colleagues, but we are very closely aligned. That's actually the ANSMOS, the Australian Bariatric Surgery headquarters. It's in the Adelaide Hills. If you get the opportunity to visit, I would strongly encourage you to do that. That's our ANSGOSA board. We've actually at times had the privilege of visiting the ANSMOS headquarters, and that's the sort of living space and their dining room where they conceived and planned this conference. That's the ANSGOSA clubhouse where we do our work. And to disclose, I think Ahmed's promised us a new boardroom table if I'm not too strong against esophageal cancer in this debate. So I really only make 4 points, and one's the IFSO guidelines, two's mechanisms, three's literature on bariatric surgery, which I think Caroline's covered very nicely, and then the epidemiology. I think the IFSO position statement on endoscopic screening is really important, and the recommendation is that after bariatric surgery at year 1, and then every 2 to 3 years, you're screening for Barrett's and esophageal cancer. Barrett's screening, regardless of which society, which is Australia, UK, European, it's very controversial whether any screening for Barrett's is recommended or any surveillance. Only about 7% of adenocarcinomas are picked up on screening, even though Barrett's gives you a 25-fold increased risk. So the question you could ask, if you're having screening after a sleeve gastrectomy, you should then have a gastroscopy every 2 to 3 years, but if it picks up Barrett's, you then get referred across to the Barrett screening department, you'd be lucky to have an endoscopy every 3 to 5 years. So it's highly manifest of a very substantially increased risk. I haven't read the position statement in detail, but there's some background that esophageal adenocarcinoma is one of the cancers where the population attributable fraction is pretty much the highest of all malignancies. And another real key point is the exposure and the latency time period, so that if, regardless of which carcinogen someone's exposed to, the accepted epidemiological period is 10 years. So if you're doing studies, the age group 35 to 45, if they're exposed, you've got to attribute a change in incidence in the age group 10 years older. Also, for the World Health Organization screening criteria, given the IFSO position statement, they would have had to have very carefully looked at this because there is significant potential harm from screening. They have to be absolutely convinced that there's an early stage of the disease. The test's got to be acceptable to everyone. You've got to understand the natural history of the condition. So they're very, very strict criteria, and a sort of organisation would look at this very, very carefully before coming up with a position statement such as this. So I could almost just finish there because I think that that pretty clearly illustrates the collective opinion on this issue. So I described the IFSO position statement in the context of this debate as an own goal. You've sort of asked me to come along and argue this, but your own position statement says, yes, we've got to screen. Quickly about mechanisms. Bile reflux and acid reflux are intrinsic to Barrett's transformation. There's different proposed pathways. These are some of the other evidence demonstrating that there's substantial associated reflux. Video's not playing. Bile in the esophagus, the normal esophageal acid exposure is at least double. It goes from 4% to 8%, even in someone who has no reflux post-sleeve. Nucleus scintigraphy scans in a standard patient coming to see an esophageal surgeon for their symptomatic reflux, you'll very rarely pick up any reflux events. In the sleeve patient, 100% will have profound reflux. So it is a refluxogenic procedure. So I've added a couple other slides here. That's a SPECT scan with the purple labelling bile. Bile gets up close to the esophagus. The red and the blue is a comparison between the esophageal activity in a nuclear medicine scan in a sleeve patient with no reflux compared to the blue, which is a patient non-bariatric with severe reflux about to undergo fundoplication. So this is mechanisms, this is the sort of smoking gun. There's not only a definitive pathway, but it's very, very suspicious and concerning. The prior literature, which Caroline covered, particularly her focus on one paper, I think there are a range of publications. There's one epidemiological publication claiming an incidence of 1 in 200 in terms of esophageal adenocarcinoma. I mean, I think that's impossible. You've got to look at what the expected rate in the population is, which is around 4 in 100,000, but that will change dramatically based on age and other risk factors. So there's 6 or 7 publications which tell us different things, but there are a few key characteristics relating to the age, so the exposure, the bariatric surgeries occurring at age around 40, and the follow-up's generally very, very short, 3 to 5 years is the mean follow-up. So they're not even getting into the either the age group or the duration of exposure where you potentially will see evolution of these malignancies. If we go back a long way to the literature on smoking and cancer, smoking and lung cancer, in these studies from the 1950s, they required a 20-year exposure and an age of 50 before people went into these studies, and that's quite different to the literature on the risk of esophageal adenocarcinoma following bariatric surgery. They're not comparable. This is the epidemiology, the raw number of esophageal cancer diagnosis in Victoria, which is a state we're in, population of 7 million. You can see that increases over time. This first black line, that's the age at which the patients in those epidemiological studies had their bariatric surgery. So they're at age of 40, where there's an incredibly low incidence for the next 10 and even 20 years of the disease. Of the cases reported in the literature, all esophageal cancers following bariatric surgery, it's around the age of 60, and the average in the population, in most Western countries, are between 70 and 77, depending on gender, but say 75. So there's a very substantial difference. And this is the follow-up in those epidemiological studies. That they followed up for a couple of years around the age of 40, but they're nowhere near that 10-year exposure, and probably 20 is what's required, and they're nowhere near in the age where we start to see these malignancies. And just as a reminder, they're the graphs from the original studies that looked at cigarette smoking as a risk factor for different cancers. They started at the age of 50, where many people would have had 30 years of exposure to that risk factor. So what I've said is that these epidemiological studies, people are saying, from the bariatric side of things, are saying, no, it doesn't fit us, it's not us, definitely not us. If you look in more detail at a longer-term follow-up, and there is one longer-term follow-up in abstract form of over 20 years, a very simple study, only 11,000 patients, but they were able to cross-match it. It's just at one centre, and this is the, I think, age standardised incidence rates. So the actual number of cases is the red and the maroon, that's in the bariatric surgical patients, and the maroon is the population rate. So there's a marked increase, but even in this 20-year cohort study, where I think the average follow-up was 13 years versus 4 to 5 years, you can see that the epidemiology hasn't shifted, because we'll be seeing a lot more cancers 20 plus years following exposure. Matching it to obesity matched controls, that there is still a markedly elevated incidence of esophageal adenocarcinoma in patients who've had bariatric surgery compared to those who have not. So I'll just summarise all that. I really only wanted to make 4 points. One is the mechanisms, which is the suspicion, the smoking gun. There is reflux after these procedures. That's what leads to esophageal adenocarcinoma, the mechanism. You only have to look at the IFSO position statement. There's clearly extreme concern in this area. You're talking about having an endoscopy at year 1 and then every 2 to 3 years after a bariatric surgery. And that includes 20-year-old females having gastric sleeve. So there must be an elevated risk. Third is what the previous literature or what the publications show, and they're just not adequate to capture that risk. The exposure is not long enough and the population's not large enough. And if you do investigate it with a study on with methodology that's designed to actually capture that risk, that's when you start to see the significantly increased rates, and that's where the concern comes from, and I think that relates to the position statement. So I will conclude on that note. I'll leave it for people to draw their own conclusions. Thank you very much.
Thank you. So I'm going to try to save you some time here. So we're going to talk about, I'm going to be in pro of defending revision choices after sleeve gastrectomy, explain the high revision rates, then gastric bypass. These are my conflict of interest. None of them have any influence on this presentation. My case, mixed disclosure. And my friend Khaled Gawdat, this is nothing against you. I'm just trying to make a point here according to this debate. But not everybody has the same response. I think we see that on all the surgeries, not only on the sleeve. You know, there's patients that will have, you know, recurrent weight gain, gradually more prevalent, but that can be based on early poor response or late poor response, and that happens on both procedures. Now, I'm sure that my opponent is going to claim that the bypass has less of that poor response and the sleeve has more of that problems. And indeed, you know, at least in the United States, you know, we have the MBSA-QIP data, and we are seeing now a transition from the types of revisional cases that were being done in the past, which were mainly band conversions to a stapling procedure. Now it has shifted to sleeve gastrectomies converted to a gastric bypass. And if you look at the data from the MBSA-QIP, true, Sleeve gastrectomies conversions are 40% of the revisional cases. The majority are being converted from reflux, and this is data from the MSA-QIP, and about a third are converted from what is being determined as poor weight loss. But one thing that we're forgetting about this is that still, based on the same MBSA-QIP data, over the last 10 years, we've seen constantly this prevalence of choosing the sleeve as the operation that everybody wants. Not only surgeons, but also patients. Everybody wants something that is less invasive. And why is that? We keep asking that question. I mean, if we have duodenal switch, why duodenal switch is still 1%, 2% of the cases? Well, the reason is this, you know, and there's many articles documenting that, but I'm just going to pull this quickly from David Sauer, is reasons for underutilization of bariatric surgery, the role of insurance benefit design. And so he was trying to make a point why patients choose what they choose for. And so it's a good survey among candidates for bariatric surgery. And it's interesting, about 20% of these candidates thought that bariatric surgery was safe enough. So if 1 out of 5 thought that surgery was enough. So if you think about that big number, many patients should proceed with the surgery. The problem is only 17% of these 20% would be willing to have surgery. Even though they thought they were safe, they still, I'm not sure if I wanted to have surgery. So they're still afraid. So that means that a total of 3.5%, this is on a survey done, participants thought that for safety reasons, they will proceed to have surgery. And that's the reason that we're still doing 1%. So we still perceiving surgery as unsafe. And if you compare sleeve to a bypass, they're perceiving more complicated surgery, more unsafe, and that's the reason that we're having that. And why sleeve gastrectomy has preference? You know, still patients are afraid of bariatric surgery. Many will not choose bypass, so we need to understand that. So can we use the sleeve as a good option to assess response rate? I don't think there's anything wrong with that. You know, sleeve pass and both trial have shown that 50 to 70% of the patients will respond well and have good weight loss equivalents at 5 to 10 years. So we have a good number of patients that will do well with the sleeve. So why would not be able to choose that and just not focus only on the one that has less revisional cases? The sleeve actually preserves the anatomy access and give you access to biliary tract and upper GI. Sleeve is easier to revise than bypass and has half the complication rate, at least initially, compared to the bypass. I don't think that's a bad option. Even one of the leaders here sitting out with us, you know, he thought that the sleeve was going to be the first stage of a 2-stage procedure. Why? Because in certain patients, you know, it's just much better to do something that is less invasive than just go ahead and do the full-blown technique and then create more complications. So hopefully that will help me with the judging of my presentation here. But I'm going to give you just a little bit of preemptive of an IFSO revisional position statement that is still not out, but I'm just going to give you the highlights of 2 conclusive sections that are going to come up of this revisional section. And I'm sorry that I'm going to give you this as a preemptive without the whole context, but revisions after Roux-en-Y are going to be determined to be more challenging for the surgeons and patients. Endoscopic revisions results are limited short-term, and surgical revision creates higher rate of complications. Now, what they're going to say about the sleeve revisions is that there are multiple options, so we still have a whole variety of options to do. We can do Roux-en-Y short and long limb, we can do re-sleeve, we can do duodenal switch, SADI, OHEB. Roux-en-Y has good midterm results, 5-year for GERD resolution. Roux-en-Y has long limb DS, AD, and all these technical complications can be used as a revisional surgery. So we still have a lot of options for the sleeve. So my conclusion is that we don't need to see it as a disadvantage if we just have to go back in. We see it as an advantage if we have options for many patients. Not everybody responds the same way. And so to me, that's the best argument that I have for you to go for what the patients want, what the surgeons are looking for, and still accept that as a test measure for patients. Thank you.
So that's a long title, right? So thank you for being here, and it's a very tough act to follow after Jaime, but I'll do my best. So these are my disclosures. So this is my bias chart. So this shows what I do. All my procedures are banded, so I do banded bypasses, banded one anastomosis, banded sleeves, very few, and 70% of my practice is revisions. So the first question here, revision choices after sleeve gastrectomy explain the higher revision rates than in gastric bypass patients. I'm supposed to be against that. Who's choosing these titles? That's weird. It took me 5 minutes to understand what these guys want. So this is the future. And you know, bariatric surgeons like the before and after pictures. I like that too. So you look here at Johnny. So in 2 weeks, he lost 2 weeks. And if you say the same thing about bariatric surgery, if you have the same picture, so in 5 years, Johnny lost 5 years. They gained the weight. So now, today we're the #1 operation worldwide debate, yes? Please remember, the voice of the majority is no proof for justice. I used to attend the duodenal switch group. Michel did that too in the late 90s, and we would sit with Hess, Morceau, Scopanaro, Baltasar, and see how they designed how to do the duodenal switch. And they did it completely different. Some would have 100 centimeter common channel, and the others have rule of thirds. Baltasar was a very honest surgeon who reported his complications, and he was consistently making his pouches smaller, shorter common channels, meaning it may not work. And for me, my experience with open DSs, I had 65 cases in the 90s, and guess what? These also fail. So none of our procedures are fail-proof. And you know, all bariatric procedures will give you a honeymoon. So we have some weight loss in the first 18 months, and then we'll have weight regain for all bariatric procedures. The results at 5 to 10 years will be completely different from your initial results. And the current problems with designing a bariatric procedure is that every procedure has a honeymoon. It takes you 5 to 10 years to know the results of what you're doing today. Also, the dilutional effect of honeymooners, if you keep recruiting new cases to the series, and the non-standard reporting and statisticulation, when you play around the statistics to get an effect. So let's remember some history. The sleeve gastrectomy, the serendipity concept. This was pointed elegantly by Michel Gagner a few years back in a nice lecture. And let's remember why did we do that? Because we had high mortality and morbidity for the very high BMIs for laparoscopic duodenal switch initially. So we said, well, let's do it two-stage approach. So this was the serendipity then. And sleeve patients did not come back for a second stage at 6 to 12 months. Why? Because we were still in the honeymoon. They had their honeymoon phase, and every stomach will stretch. So now we have in the Middle East the concept of having a relaxed sleeve to be more comfortable for the patients, and that would tend to get widened quicker, dilate quicker. Narrow sleeves are more uncomfortable, take longer to dilate. And by the time the inevitable long-term failures will appear, we'll have many failures. And now, well, let's rewind forward to serendipity 2.0. So gastric bypass elevates the GLP-1, sleeve doesn't, so now we have GLP agonists again. My definition for sleeve gastrectomy, because I don't do it, it's an irreversible reflux-inducing radical gastric resection that gives you temporary gastric restriction. So why do we revise a sleeve? Weight regain, suboptimal response, GERD, and intrathoracic migration. This is an elegant systematic review that shows that 6 years we have 75.6% failure. Also, nobody can debate the GA reflux and the intrathoracic migration as causes for the revision. And you know, we always have the confirmation bias. And you know, we all have the inherent tendency to search for evidence that already meshes with our beliefs. And it's a nature of confirmation bias itself to dismiss all contradictory evidence as irrelevant. So my evidence is always the rule, your evidence is always a mistake or an exception. So choices for revision gastrectomy, yeah, we have many choices. Re-sleeve, it should be done only in technically inadequate primary sleeves, conversion to one anastomosis, Roux-en-Y, SADS, BPD, DS, conversion to bipartition procedures, and in my practice, conversion to banded gastric bypass. So we have many revision options. And also we have many revision options for the bypass. We can reverse it, we can resize the pouch and stoma, we can distalize, convert to SADS, BPDS, conversion to sleeve gastrectomy, and some surgeons will convert it to one anastomosis gastric bypass. So could revision choices, this is the question that's being asked today. Could revision choices after sleeve gastrectomy explain the high revision rates? You know, when you do a re-sleeve for a sleeve that already was good in the first place, it doesn't work. And when you do a hiatal hernia repair for reflux on the sleeves, with the sleeve, if the patient has reflux, that also doesn't work. And if you have a Roux-en-Y gastric bypass post-sleeve, it works very well for reflux, but it doesn't work well for weight loss. We've had a big series of these cases, and they had actually weight gain. You know, the truth will set you free, but first it will piss you off. And facts do not cease to exist because they are ignored. I met this lovely gentleman, Sir Alfred Kosheri, and he said, there are patients whom we cannot help, but there are none whom we cannot harm. So the conclusion is revision choices should be against this. Yes, revision choices after sleeve gastrectomy do not explain the higher revision rates in gastric bypass patients. But suboptimal weight loss outcomes, GERD, and intrathoracic migration after sleeve gastrectomy explain the higher revision rates in gastric bypass than in gastric bypass patients. Thank you very much, and I invite you all to join us in the IFSO MENA conference in December in Egypt. Thank you.
Thank you very much, esteemed Chair, audience. So I am debating for robotic-assisted sleeve gastrectomy. Those are my disclosures. And I have to say, what an honour to be here with the Chair, Michel Gagner. Everyone very well knows the story, the man that brought the sleeve gastrectomy to the forefront of our bariatric procedures. And over the last 20 years, he has fought tooth and nail against the traditionalists to allow for that. And I, with the same vigour, will fight for robotic surgery. And also to my esteemed opponent, Dr. Reza Adib, arguably Australia's most experienced laparoscopic surgeon and most famous laparoscopic sleeve gastrectomy surgeon. So I just wanted to take a moment for myself at Melbourne IFSO on the plenary and to say I really need to enjoy this moment. So that is something that I say to myself every time after the patient has been anaesthetised, the port has been placed, the robot is docked, and now I'm at the console and I can control every variable that I need to control. I say to myself, I need to enjoy this moment, and only a robotic surgeon would know that feeling. So when I talk about robotics, I just want people to substitute in computer-assisted surgery. So here we're talking about every movement is a data point, every sleeve has a dimension, every hiatus or hiatal repair has an algorithm. So we're going to collect these data points and hopefully strive for the perfect sleeve. But when you compare the evidence for any laparoscopic operation that's now done robotically, it goes through these different phases. So first you'll have a feasibility study, and yes, it can be done. And then there'll be some concern in regard to increased complications on the robotic platform, and certainly that has been seen. And then there's some time that the procedure becomes equivalent, and that's probably where we are at the moment with the sleeve gastrectomy, though I predict with artificial intelligence, machine learning, that we will get it'll get to be better. But as the original sleeve gastrectomy came out and there was a very heavy bias against that, you also need to watch out for anti-robot people. So what we all share as bariatric surgeons is that we operate on the most difficult of body habitus. So every abdominal wall is thick. The robot effectively negates the effect of BMI. So you would not know when you're at the console how thick your patient's abdominal wall is. That within the ports, so this is just the intuitive ports, there's a remote centre control which becomes the fulcrum for movement, so that effectively negates the effect of BMI. So this has started to come out in the literature, at least in some longitudinal studies, that perhaps for the super morbidly obese there might be some benefit in terms of decreased bleeding and decreased leak rates in this cohort. But here is the kicker. It's like these BMI 60 plus patients are very difficult to operate on. So if you choose just to use the robotic technology on these difficult people, it to me is like akin to learning a new language. So if I want to become fluent in talking French, but I said I only want to talk French if I want to speak romantically or if I'm in France, and these were the only opportunities I took to practice that language, then I would never gain fluency in that. So someone wise once says the robotic approach benefits those that use it routinely. And there is our sleeve gastrectomy. It's our workhorse, at least by Australian registry data. About 85% of the cases that we're done, it can set you up for success and can be used for fellow training. So just to go through some of the other benefits of the robotic platform, for me, what I like about the robotic stapler is that extra degree of articulation. So instead of just articulating one plane, you also got the other plane of articulation, which I feel creates a very nice and neat staple line. Also, it's got arguably the most advanced stapling technology. It can tell what the tissue thickness is about 1,000 times per second. That's with the Smart Fire technology, and I think the stapling devices are going to become more and more advanced. Certainly, it's more comfortable to operate this way, and every iteration of the robotic platforms improves on that ergonomic profile. May even promise tremor reduction, career extension. And the theme for this conference is integration. So this is one patient. I've integrated the use of ICG to assess biliary anatomy for concomitant procedures, so cholecystectomy, hiatal hernia repair, and sleeve gastrectomy on the one patient with the same port positions in comfortability. ICG can also be integrated to look at tissue perfusion or hemostasis, or even with leak testing. So for me, that's where we will find a perfect sleeve. It's where all our moments on a robotic platform are captured with the data, and we can strive to improve our global surgical consciousness in our desire to perform the perfect sleeve gastrectomy. I'm based on the Gold Coast, and this has been one of my life's privileges, so thank you very much. Here's to you, Reza.
It's difficult to take this podium when everyone on that book was sitting in this room, including the master. Look, they have given me this very difficult topic to talk about. sleeve gastrectomy versus robotic gastrectomy, when everyone knows where the answer is. In fact, the gist of it was published by Zhu and his colleagues in Journal of Surgical Endoscopy recently. I have to confess my only disclosure is that I don't do robotic surgery. I have a bariatric practice. If you know, it changed through the years, as I said before. It averages, I've tamed it down to about 1,000 operations a year, and I don't count balloons in. It's the actual operations between bypass and sleeves, and revisions are they were about 1,400. It's now been reduced to about 1,000 a year, per year. I negotiate, 80% of my patients don't have health insurance. So I negotiate with my hospital. I only work in one place, and I negotiate a limited health insurance under my care. I bring revenue to the hospital, and they insure my patients against any reoperation, against any immediate return to theater, going to intensive care. So every dollar counts. And I need to have the skills and organization based on best outcome, least headaches, optimal operative time, optimal length of stay, optimal post-op complication, and most importantly, best clinical outcome. I didn't make up this list. This is only a couple of weeks ago. At 7:30, I go to my first operation theater. At 8 o'clock, I'm on the other one. At 8:30, I go to one. At 9 o'clock, I'm on the other one. Everything included, hiatus hernias repaired, omentopex is done, everything done. But every minute is counted for. Staff are like an absolute symphonic orchestra when they work. Everything has been done years and years and years of in the making. So talk about operating time. Enrique Li, they showed in 2015, that was the early onset of robotics. They showed 110 minutes for robotic, 84 minutes for sleeves. I'm sure it could even be better. Alizadeh, I don't know why I chose someone called Reza, because he's elegantly shown that his results were 102 versus 74, and Hassan Nasser showed 102 versus 70. So every second counts for us. Maybe that's one of the reasons. Length of stay, again, 1.8. The length of stay, I shouldn't really bang on the length of stay a lot because it's very similar. I mean, you can't say that length of stay is all that different between the two, and clinical outcomes. So they have shown that 1.8 versus 1.7. Please don't let me talk too much about this one. Post-operative complications, slightly higher, not statistically significant, slightly higher. Hassan Nasser in 2020 showed maybe in a higher BMI. And interesting, if I could wish for being a robotic surgeon, is when I operate on BMI 76 and 79, because it really hurts your shoulder, and the beveling and angling of your pores sometimes could hurt you. But slightly higher leaks, not statistically significant. Surgical site infection, and they showed it's ever so slightly higher in robotic than laparoscopic. We said every dollar counts. The cost, depending on how you look at it, the cost of equipment, or altogether the cost of staying in the hospital, the cost of utilization of the operation theaters. In different studies, they actually look at different things. They were showing up to 38 to 54. That's almost like $15,000. That p-value, we didn't make it up. It's actually, the cost is very obvious. I can't talk about clinical outcomes, but I can talk about cost. Every paper, and I think the most good meta-analysis was Zhao's paper in 2024, this year. They all showed that the cost is very well described. About, they talk up to $15,000. Clinical outcome, I can't really say. I mean, in the meta-analysis, they in the meta-analysis, they said that robotic sleeve gastrectomy does not demonstrate advantage. So I can't say they are behind in clinical outcome. So both groups are comparable. Robotic didn't show any advantage. Maybe they hurt less, for the surgeon, shoulders and hands. And I'm pretty sure you look very comfortable in that photo. Learning curve. Look, you want to have an operation that you can do from Saskatoon, is that right? From far in Canada to Guatemala to Pakistan, everywhere. Set up one and treat this disease, treat obesity. If you're dependent on a robot and your hospital want to argue with you and the cost and all that, I'll leave that to the audience to decide if it's a good thing to use for learning curve and all of that. I don't know. I'll leave it entirely to you. In summary, they're both effective for weight loss. There's no doubt about it. Laparoscopic sleeve gastrectomy is less technology dependent. You could just do it. Just give me a stack. I can go to Samoa. I can go anywhere that there's problem with diabetes and morbid obesity. I can just do a laparoscopic sleeve gastrectomy in one of those portable army theaters. It really is not technology dependent. The cost is lower, shorter operating time, every dollar counts. Few comparable but few post-op complications. And my typical, I talked about that one, so I just go. And this is me on that day at 2 o'clock. She's docking for her second sleeve. I'm climbing a mountain. I'm already 30 kilometers into my ride. So please don't be fooled. It's a good operation. Laparoscopic sleeve gastrectomy is still a good operation. And by the way, I think I saved $193,068 overall for my system. Thank you.